This is Hero from Navigational Interpretation and Analysis of Neuronuclear Imaging.
I'm you, an assistant.
I will talk about neuronuclear medicine in cerebrovascular diseases. The role of brain perfusion SPECT in cerebrovascular diseases is as follows. First, to detect brain perfusion abnormality in stroke. Second, to evaluate brain perfusion reserve. In addition, it detects hyperperfusion syndrome after carotid endarterectomy or carotid stenting. The threshold of cerebral blood flow in neuronal injury is as follows. Between 2/5 and 1/5 of normal cerebral blood flow is known as the functional threshold, a condition called ischemic penumbra, in which neurons are not dead but not functioning. In this state, the EEG disappears. Furthermore, when cerebral blood flow drops below 1/5, cell membrane damage due to ion pump failure occurs. Thus, measurement of cerebral blood flow is useful for detecting ischemic penumbra that has not yet reached cell death. Let's look at a case of acute cerebral infarction after 2.5 hours after onset. X-ray CT shows no obvious abnormality. Brain perfusion SPECT shows a marked decrease in brain perfusion over a large area of the left cerebral hemisphere. Brain perfusion SPECT is useful in determining the indication for thrombolytic therapy. CT and brain perfusion SPECT on the day of onset of subarachnoid hemorrhage. The CT shows bilateral hemorrhage in the subarachnoid space. The patient has left hemiplegia, but the cause is not clear from the CT. Brain perfusion. This is a case of aphasia with reversible ischemic neurological deficit in which symptoms lasted more than 24 hours but completely disappeared within 3 weeks. Brain perfusion SPECT at 3 hours after onset shows decreased perfusion. When reading brain perfusion SPECT in cerebrovascular disease, it is necessary to understand the vascular territories in the brain. The blood vessels of the brain can be divided into the anterior internal carotid artery system and the posterior vertebrobasilar artery system. The internal carotid artery branches off the anterior cerebral artery and the middle cerebral artery. The internal carotid artery also branches off the anterior choroidal artery, a deep perforating artery. The anterior choroidal artery supplies the anterior half of the choroid plexus, the anterior half of the medial temporal lobe, and the posterior portion of the internal capsule and the internal segment of the globus pallidus. The anterior cerebral artery supplies the anterior 2/3 of the cerebral hemispheres on both sides, and the deep perforating artery supplies the area around the head of the caudate nucleus. The middle cerebral artery supplies most of the lateral portions of the cerebral hemispheres bilaterally, and the deep perforating artery supplies the basal ganglia. The posterior cerebral artery of the vertebrobasilar artery system supplies the posterior half of the medial temporal lobe to the medial occipital lobe of the bilateral cerebral hemispheres and supplies the midbrain and thalamus with deep perforating arteries. These vascular territories are shown in transaxial section. This is followed by a coronal section showing the territories of these vessels. The territories of these vessels in sagittal section are shown. The perforating branch of the anterior cerebral artery is also called the medial striatal artery, and the perforating branch of the middle cerebral artery is also called the lateral striatal artery. After understanding these vascular territories, let's look at a brain perfusion SPECT of cerebral infarction caused by occlusive cerebrovascular disease. The first case shown is a cerebral infarction caused by occlusion of the left internal carotid artery. Brain perfusion is reduced in a large area of the left cerebral hemisphere. This is the territories of the anterior and middle cerebral arteries. There is also decreased blood flow in the left striatum. This is a case of cerebral infarction due to occlusion of the M2 portion of the left middle cerebral artery. There is decreased blood flow in the cerebral cortex of the left cerebral hemisphere. The occlusion after the bifurcation of the perforating branch of the left middle cerebral artery maintains the perfusion of the left striatum. This is a case of cerebral infarction in the right posterior cerebral artery territory. Decreased perfusion is seen in the medial part of the right occipital lobe. This is a case of cerebral infarction in the left anterior choroidal artery territory. Perfusion is decreased over a wide area from the left basal ganglia to the left thalamus and from the medial part of the left temporal lobe. This is a case of infarction of the perforating branch of the right middle cerebral artery. The infarction was in the territory of the lateral striatum artery, and decreased perfusion was seen in the right putamen. Decreased. Let me explain the relationship between brain perfusion and metabolism. Under normal conditions, brain perfusion and metabolism are correlated, and brain perfusion is also related to brain function. In misery perfusion, brain perfusion is reduced compared to metabolism. This is seen in the acute and chronic phases of ischemic cerebrovascular disease. Luxury perfusion is a condition in which brain perfusion is excessive compared to metabolism. It is seen in the subacute stage of cerebral infarction, recanalization due to autolysis of thrombosed arteries, and after carotid endarterectomy or carotid artery stenting. Left anterior cerebral artery territory cerebral infarction, subacute stage. There is a marked perfusion increase in this artery territory is thought to be luxury perfusion. This is a case of increased perfusion thought to be after recanalization by autolysis of a thrombosed artery. Right hemiparesis and aphasia improved in a few hours after onset. Increased perfusion is seen in the infarcted area from the left temporal lobe to the parietal lobe. Let me explain the remote effects I mentioned earlier. There are two types of remote effects. First, diaschisis, as defined by von Monaco, is a neurophysiological change at a site remote from the local lesion. It is a functional deafferentation caused by the loss of input information from the affected area. The most famous example is crossed cerebellar diaschisis via the cortico-pontocerebellar pathway. The idea that damage to one part of the nervous system can have effects at a distance became popular during the 19th century. Constantin von Monaco, M.D., accepted this idea and blended it with the newly formulated neuron doctrine early in the 20th century to account for ipsilateral paralyses and recovery of function. He called his theory of neural depression caused by loss of inputs to structures tied to the damaged area diaschisis. Another remote effect is called transneuronal degeneration. It refers to the death of a neuron as a result of disruption of input or output to other nearby neurons. It can be either anterograde or retrograde, indicating the direction of degeneration relative to the original site of damage. There are remote effects mediated by cortical basal ganglia thalamic cortical loop, cerebellar rubrothalamic tracts, thalamocortical tract, and corticospinal tract. The neural pathways associated with the remote effects are shown. The cortico-pontocerebellar tract is shown in red. It leads from the cerebral cortex to the ipsilateral pontine nucleus and then to the contralateral cerebellar hemisphere. The thalamocortical tract, shown in green, runs from the thalamus to the ipsilateral cerebral cortex. The cerebello-rubrothalamic tract, shown by the blue line, leads from the cerebellar dentate nucleus to the contralateral thalamus via the contralateral red nucleus. The cortico-basal ganglia thalamocortical loop is shown. The cerebral cortex, striatum, thalamus, subthalamic nuclei, the external and internal segments of the globus pallidus, and pars reticulata and pars compacta of the substantia nigra are connected in manners of excitation, inhibition, and modulation. Remote effects are manifested through this complex pathway. Let's take a look at the remote effect in a case of right putamenal hemorrhage. CT shows that the lesion is located from the right basal ganglia to the posterior limb of the right internal capsule. However, the ipsilateral thalamus, ipsilateral cerebral cortex, and contralateral cerebellar hemisphere also show decreased perfusion. Remote effects also occur via the corticospinal tract. The corticospinal tract runs from the motor cortex of the cerebrum, through posterior limb of the internal capsule, down through the cerebral peduncle, pontine base, and the pyramid, to the contralateral spinal cord at the pyramidal decussation at the cervicomedullary junction. One of well-known diseases that affects the corticospinal tract is adrenoleukodystrophy. The location of the corticospinal tract can be determined by high-intensity on T2-weighted images in the posterior limb of the internal capsule and medulla oblongata. Let's see how a small infarction in the posterior limb of the internal capsule affects brain perfusion. SPECT diffusion-weighted image shows an acute infarction in the left posterior limb of the internal capsule. Brain perfusion SPECT shows a mild perfusion decrease in the left thalamus. The infarction in the left anterior choroidal artery territory may have caused ischemia in the medial segment of the globus pallidus, which had a remote effect on the ipsilateral thalamus. This is a fusion image of brain perfusion SPECT and diffusion-weighted image. Comparison with the normal database of brain perfusion SPECT shows decreased perfusion in the left precentral gyrus. This is thought to be a remote effect via the corticospinal tract. We move on to the topic of brain perfusion reserve. 3 types of indices are used to evaluate brain perfusion reserve. When cerebral perfusion pressure decreases, cerebral blood vessels dilate to maintain cerebral blood flow. Therefore, cerebral blood volume is used as an index of reserve capacity. It is also known that cerebrovascular mean transit time, which is obtained by dividing cerebral blood volume by cerebral blood flow value, is directly correlated with oxygen extraction fraction. Furthermore, cerebral vasodilatation capacity can be evaluated to assess brain perfusion reserve. For this purpose, inhalation of 5% carbon dioxide gas or administration of 500 mg to 1 gram of acetazolamide, a carbonic anhydrase inhibitor, are used. This figure shows the staging of cerebrovascular reserve associated with decrease of cerebral perfusion pressure. In stage 1, cerebral blood vessels dilate as perfusion pressure drops, and an autoregulatory mechanism is activated to maintain constant cerebral blood flow. The cerebral blood vessels can no longer dilate in response to a further decrease in perfusion pressure, and cerebral blood flow decreases. On the other hand, oxygen metabolism is maintained by increasing the oxygen extraction fraction. In stage 3, cerebral blood flow is further reduced, oxygen metabolism is also reduced, and the patient will suffer from infarction. Here is a summary of the staging of hemodynamic failure. Stage 1 shows dilatation of cerebral blood vessels, while Stage 2 shows increased oxygen extraction fraction. For the purpose of determining this staging, PET with O15 gas inhalation is performed. Recent PET systems are combined with CT, and the CT system is in the foreground. O15 gas inhalation PET measurement requires measurement of oxygen content in arterial blood. Therefore, several arterial blood samplings are required during PET imaging after securing the arterial line. In order to facilitate arterial blood sampling, patients are asked to enter the PET-CT in the opposite direction. The following is a procedure of PET measurement using O15 gas inhalation. First, if O15 CO2 gas inhalation is continued for the purpose of measuring cerebral blood flow, the radioactivity in the brain reaches a steady state. Since the half-life of O15 is 2 minutes, the next measurement of oxygen metabolism using O15 oxygen gas inhalation can be performed in about 10 minutes after the gas inhalation is stopped. Finally, the patient is asked to inhale O15 carbon monoxide gas, and cerebral blood volume measurement is performed. In this protocol, a total of 5 arterial blood samplings is performed. These are scenes of PET measurement using O15 gas inhalation. O15 gas inhalation by mask and arterial blood sampling are performed. This image shows oxygen metabolism by oxygen from O15 gas inhalation, cerebral blood flow by carbon dioxide, and cerebral blood volume by carbon monoxide. Cerebral blood flow and oxygen metabolism images of an 8-year-old boy with Moyen-Wire disease. This is a case of right internal carotid artery occlusion in an early 70s woman. The flare shows an ischemic lesion in the right semi-oval white matter. O15 gas PET shows a slight increase in cerebral blood volume in the right cerebral cortex. There is no decrease in cerebral blood flow or oxygen metabolism, and there is no increase in oxygen extraction fraction, suggesting a hemodynamic failure stage 1 condition. When the carbonic anhydrase inhibitor acetazolamide is administered, the pathway by which carbon dioxide gas is exhaled from brain tissue to the blood and then to the outside of the body through the lungs is disrupted. As a result, the partial pressure of carbon dioxide increases, causing cerebral blood vessels to dilate and cerebral blood flow to increase. Brain Perfusion SPECT using I-123-IMP can evaluate cerebral blood flow at rest and during acetazolamide loading in a single test, which takes approximately 1 hour. The I-123-IMP is administered twice, and an arterial blood sample is taken 10 minutes after the first dose to measure the radioactivity of the arterial blood. Understanding the arterial circle of Willis is necessary to understand how hypoperfusion occurs in occlusive cerebrovascular disease. Even if there is occlusion of the unilateral internal carotid artery, if the Willis circle is intact, there is usually no decrease in cerebral blood flow to the contralateral cerebral hemisphere through the anterior communicating artery. However, there are variations in the arterial circle of Willis. When the A1 portion of the anterior cerebral artery is hypoplastic, the pathway through the anterior communicating artery does not work, and when the internal carotid artery is occluded, cerebral blood flow to that vascular territory is reduced. In addition, if the P1 portion of the posterior cerebral artery is hypoplastic, the posterior cerebral artery territory is perfused from the internal carotid artery territory via the posterior communicating artery, resulting in a decrease in perfusion pressure in the posterior cerebral artery territory in case of internal carotid artery occlusion. This is a case of left internal carotid artery occlusion. Hypoplasia of the A1 portion of the left anterior cerebral artery was observed. At rest, cerebral blood flow in the left internal carotid artery territory is already reduced. In this area, the cerebral blood vessels are already dilated. After acetazolamide, Diamox, loading, the left internal carotid artery area is not further vasodilated. On the other hand, in the right cerebral hemisphere, where no occlusion was observed, cerebral blood flow increased due to vasodilation caused by acetazolamide loading. This indicates that the cerebral perfusion reserve in the left internal carotid artery region is decreased. After anastomosis of the left superficial temporal artery and left middle cerebral artery, cerebral perfusion reserve improved and cerebral blood flow during acetazolamide loading increased compared to before surgery. This is a case of severe stenosis of the right internal carotid artery and hypoplasia of the P1 portion of the right posterior cerebral artery in a late 60s man. Infarction occurred in the right posterior cerebral artery territory due to decreased perfusion pressure. O15 gas PET shows decreased cerebral blood flow in the right temporoparieto-occipital area, but the decrease in oxygen metabolism in the same region is mild. Cerebral blood volume and oxygen extraction fraction increased in the right middle cerebral artery and posterior cerebral artery territories, suggesting a hemodynamic failure stage 2 condition. In this case, right internal carotid artery stenting was performed. After stenting, cerebral blood flow in the right temporo-occipital area increased, oxygen extraction fraction OEF and cerebral blood volume CBV did not increase. Brain Perfusion SPECT by 123-IIMP showed that the decrease in cerebral perfusion reserve caused by acetazolamide administration was not seen after surgery. After carotid stenting or carotid endarterectomy, one must be aware of the occurrence of hyperperfusion syndrome. It is estimated that this hyperperfusion syndrome occurs in 4.6% of carotid stent procedures. Cerebrovascular injury due to hyperperfusion syndrome occurs in 47% of cases, and 54% of these cases are fatal or result in permanent disability. It has been reported that patients who have decreased cerebral perfusion reserve prior to surgery are at higher risk of developing hyperperfusion syndrome. Here is a case of hyperperfusion syndrome in a patient who underwent right internal carotid artery stenting. Preoperative acetazolamide loading showed a decrease in perfusion reserve in the right internal carotid artery territory. 2 days after stenting, hyperperfusion was observed in the right cerebral hemisphere cortex and decreased perfusion due to a remote effect in the left cerebellar hemisphere. Thank you for listening. If you have any questions,